you hear me?
If we can have your attention once again. We promise we got to get started this time. We can have your attention.
Yay! Yeah, I can hear you. Oh, great. Okay.
And there is a video option if you're able to enable it.
Oh, that's right. Okay, let me do that. Sorry. Is that going to overwhelm your internet?
Okay. Oh, welcome, Monika.
Hello, everyone.
Welcome, Monika. Great to have you here. There are about 350 people eager to hear your story.
Hi, everybody. I'm glad this worked out.
And I've already introduced you to save time. So let's start with having you give us a brief explanation about how the Medicare healthcare system works in Canada and how it came into being.
Okay, and I'm just doing one sound check. Everything sounds okay when I talk? Yeah. Oh my goodness, that's an enthusiastic crowd. Healthcare in Canada, I just want to check because I can't hear an echo. Is that just me hearing it or can you hear it too?
You're good.
I'm good. Okay, I'm just going to ignore the echo then. Okay, so the way our healthcare system works in Canada is we have a universal, single-payer, publicly funded healthcare system for medically necessary. Oh my goodness, I get so many cheers without having to do anything. For medically necessary hospital and physician services. And I know actually that wasn't cheers for me, that's cheers for single payer healthcare, which yes, is fantastic. So the way our system works is that if you need to access physician services or hospital services that are medically necessary, there is no issue with you accessing them. You get those services based on whether you need them or not on your ability to pay for them. And then in terms of how our system evolved, it was over about a 10-year period with different pieces being added on in subsequent years. But it started with after the Great Depression with a sense that we needed a single-payer, publicly funded system. And it actually started first in a province in central Canada, Saskatchewan, which is a province with a fairly small population. It's about 1 million people now. It was far less at that time. And it was through public pressure as well as a very visionary leader, a premier of the province, that they first brought in single-payer, publicly funded, universal hospital services. And once people realized how much better of a system that was, a few other provinces started doing it. And then eventually the federal government said, we will cost share with the provinces and territories. So then when the federal government kicked in money, all of the provinces and territories all converted into a system for hospital coverage. And then a few years later, that same province, Saskatchewan, decided to introduce publicly funded universal care through physicians. And that was actually more of a fight because at the time there was a lot of physician opposition to that because physicians were worried, and I'm sorry that it's my own profession, but people were worried about their incomes being affected and of course, similar things that you're probably seeing in the US. But despite the opposition, despite physicians going on strike, there was so much support from the public, so much support from the politicians that were leading the efforts. There were definitely politicians who opposed it, but in the end, that same province, Saskatchewan, brought it in, and then eventually the entire country, especially again as the federal government kicked in funding. So it was all over about 10 years initially, and then over following years got further entrenched in our healthcare system.
Great. If you could help us understand what the system covers, what it doesn't cover, and how it's paid for.
Sure. So the coverage is for medically necessary physician and hospital services. And people often ask, who decides what's deemed medically necessary? And essentially it's the healthcare provider and the patient together that decide what's medically necessary. So when I see a patient, together we look at what needs to happen, what they need to have done. It can be ordered, the referrals can be done, but that's how it's decided. So across the country, that is what's covered. And there are things that do not fall under that, although the initial vision of Medicare did have many other aspects to it. It doesn't always cover things like dental care, physiotherapy, occupational therapy, other pieces that aren't physician or hospital services. That being said, any province or territory can decide to cover certain aspects. So there are often public options for physiotherapy, public options for dental care. So any province can add on to that, but hospitals and physicians are always going to be covered if they're considered medically necessary. And it gets paid for through our taxes. So all of us, we have a progressive tax system in Canada. It could be even more so, but that's how we pay for our healthcare. And taxes in Canada are no more than they are in the US, and they're actually often far less. And on top of that, we don't have the additional healthcare costs that people need to bear often in the US, because I never have to charge my patients. They never have to take out their credit card when they go to the emergency department or see a physician.
Excellent. So tell us about the role of private...
Oh, you just went. Hold on one second.
So that's really helpful. Yeah. If you could now help us understand the role of private insurance, supplemental insurance in Canada, that would be awesome.
Sure. So we still do have a supplemental insurance system in Canada, but you are not allowed to cover the same services that Medicare covers. So it's called duplicative insurance, so duplicate insurance that does not exist for publicly funded services through Medicare. But what there is insurance for are things like drug coverage for those other pieces like dental care and physiotherapy and occupational therapy. So we actually have a whole host of different public plans, as well as hundreds and thousands of, even for just drug coverage, different plans. And it's actually a big push in Canada right now, in particular, to have national pharmacare, because the way our system works is our drugs are covered in hospital, but as soon as you walk out the door, for many people, they're no longer covered. And we also know that, that private insurance is often not a great way to cover these medications or cover these services. So it's actually a big election issue for us right now. We have a federal election happening, and one of the big hot topics is national pharmacare and whether which parties support that. And we're hoping that can come under Medicare, because it should be there. It doesn't make sense that it's not.
Awesome. So there's a myth that Canadians don't have wide choice of doctors, that doctors are employees of the state. Can you help dispel that myth?
Yeah, there's, I guess, two parts to that question. One is that we don't have our choice in physician. So wherever you live, there will be a number of different physicians there. And in our system, the family physician is the gateway to all the other services. So the family physician is who refers you on to a specialist, but you're not tied to any one physician. You can see the physician of your choice. Of course, sometimes one practice might be full. You may need to go to another one, but no one dictates to you which physician you need to go and see. And the second part was around physician payment. So the way it also works in Canada, the vast majority of physicians bill the public system. So we see our patients, there's a fee that's been negotiated with the province. That's what we get paid. We bill the public insurance program for that fee, and that's how we get paid. So about 75% of physicians get paid in that way. They're independent contractors. They're not employees of the province or the country. And then a small number of physicians get paid in other ways, but the vast majority bill our public insurance program.
Thank you. So the system sounds like it works a lot like Medicare in the US, except only better, right? It's social insurance with open access to doctors and hospitals and no out-of-pocket costs for medical and hospital care. Is that right?
That describes it, yeah.
Excellent. So what in your view is the biggest strength of the system?
I think it's pretty much what you just said. The fact that as a physician or as a patient or any of my patients, we do not need to think about payment. It's not that you never have to think about cost, because, you know, you can only order what exists, but at the same time, I don't ever feel that I'm hampered by the fact that a patient can't pay for the care that I think they should have. I never say that the system is perfect. There's lots of things we still want to improve, but that baseline, that we have this equitable system that no matter what your income or your background, you can walk in and see a physician or go to the emergency department or be in hospital, and at the end you don't need to worry about the payment piece of it, is by far the best part of our system. I'd say there's still things that we need to improve. I tend to work in smaller and remote communities, and so there's always going to be a balance of how do you make sure, you know, everyone has equitable access, whether they live in a 1,000 person community or downtown Toronto. But all of those problems can be looked at in a single payer system. Single payer makes things better, and we can work within that single payer system to improve what's there.
Great. So there's also a myth about wait times when people have emergency and acute needs, and it'd be great if you could speak to that.
Yeah, and it was interesting when Diana and I were talking earlier around trying to compare Canadian and US wait times. I realized it's really difficult to do that because it's so hard to get that data in the US. Whereas in Canada, because we have this single payer system, because government has that data, it's much easier to even know what our wait times are. And we have a very robust system in terms of measuring wait times across the country. And what we know is that, especially when you need acute or emergency care, you get that care in the time that you should be getting it. You know, you may hear horror stories about people who don't get that, and that's truly a myth. We do very well in terms of being able to provide acute and emergency care to people. Then there's the layer of services that are not acute but are still very important to people. And we know from our data that about 70% of all Canadians are able to access the care that they need according to the benchmark waiting times that they should be getting it in. And sometimes it's actually much higher than that. Sometimes it is lower than that. But the majority of Canadians get access to even the care that isn't emergency or acute in the time that they should be getting it.
Great. So there's a question about coverage of mental health services, and then it would be great if you could speak to where there are waits and what's going on in the country to address wait times.
Mm-hmm. So mental health services is a mix again across the country. So it's definitely a hot topic here about needing to have better mental health supports, especially since, for example, we're struggling with some of the issues around opioid use and other kind of outcomes that may come from lack of access to mental health services. So that is an area, again, apart from psychiatrists and physicians, that different provinces and territories decide what is covered. So in some places, you may be able to access mental health services more quickly than other places. That being said, the current government, which who knows if it'll still be the government after Monday, has put a lot of investment into mental health and very much earmarked specific money, which is what the federal government here can do. They earmark certain money from a certain area, which in this case was mental health, and that's helped to decrease wait times across the country for mental health services. And there was a second part. I forget what the other part was.
It was just how the country is addressing wait times.
Yeah, that's somewhere we've definitely made really big strides. And when there's all kinds of different solutions that you can look at. And for example, one that's been really key in a lot of provinces, especially for surgery wait times, is having centralized referral processes. So it used to be in most places that, a doctor would refer to a certain doctor that they may know well, or that, they're friends with, or, have had good outcomes with, but that doctor's waiting list might be really long, whereas another doctor who's just as good may have a really short waiting list, but I have no way to know that. So what's changed significantly is that many more places are using centralized referral processes so that it goes into a pool, the next surgeon available takes that person, and it has significantly decreased wait times, especially for surgical procedures all across the country. Another example is that we're having a lot more telehealth, so using video referrals for specialists, especially again where I tend to work in smaller communities. It's been such a change because normally people would need to travel to another place hours away, but to be able to access a specialist by video when that's appropriate has been an incredibly valuable way to decrease wait time. So there's a number of different initiatives that have happened across the country depending on what the different needs are according to wait times.
We have lots of questions here.
Yeah.
One question was from the audience was whether in different provinces providers are paid different rates.
So yes, so when I was thinking about exciting things that could happen in the US, that you have this opportunity to truly create a national system. In Canada, constitutionally, healthcare was given to be the responsibility of provinces. So every province negotiates fees with their physicians. So there's not going to be huge differences, but there are definitely differences across the country. So each province and territory has its own fee schedule that's negotiated, that the physicians get paid by. Whereas if you start at scratch and have a national system, you don't need to have that added layer of all these differences across the country.
Another question from the audience is how provider rates in Canada compare with provider rates in the US.
So again, we can collect that data really well because we have this information through our provincial systems. And so there's often talk of physicians in Canada being paid much lower than in other places, but physicians in Canada are still amongst some of the highest earners in the country. Ranges anywhere from about 250,000 up to 500,000 or more. We now have physician salaries that get published when any government paid person gets salaries published in a number of different provinces when they're above a certain level, and physicians are often on that list. So it's almost embarrassing to tell you that physicians make a lot of money in Canada, but many do, and they're making equivalent, maybe not quite as much always as in the US, but are making a very good income in Canada, especially compared to the rest of the population. Great.
Another question goes back to the issue.
Oh, 1 second, you're muted again.
Oh, sorry. There's a back lash if I keep it on.
Okay. Oh, okay. Yeah.
So that I keep turning it on and off, sorry. So another question goes back to the issue of supplemental coverage and long-term care, and whether supplemental coverage covers long-term care, and if so, does it cover the full array of home and community-based services that people need?
So definitely, I think when you look at things that should be part of our publicly funded system, things like home care and long-term care are pieces that are not always publicly covered. So again, going back, they don't fall under that physician and hospital service basket, even though they were meant to be part of the initial vision of Medicare in Canada. So there are public options, and it's province by province as they decide what to cover and what not to cover. And also with supplemental insurance, it depends on your insurance. It depends if you have insurance. We also have many people who don't have insurance. And so long-term care as well as home care are pieces that often there is some public coverage, but it's definitely an area that we need to have more public universal coverage of.
Great. I want to turn now to the situation today and the threats to universal health care in Canada. And just to be clear with the audience, you've helped me understand that nobody can pay more and get to the front of the line today in Canada, but there is a threat of by doctors who want to be able to get paid privately. So it'd be great if you could speak to that.
Sure. Yeah. So in terms of things that we're really worried about in Canada, the one big one right now, it's a court case that's happening in British Columbia, so on the West Coast, and it's a court case that's in the Supreme Court there that's been brought by a physician, an orthopedic surgeon, who on behalf of his two companies has brought this court case because he wants to have three things, and I'll try to explain them kind of quickly and simply. One is he wants to be able to have that duplicate insurance that I mentioned, so a private option for the things that are normally covered through our publicly funded system, which you are not allowed to have right now. The second thing he wants is to be able to work in both the public and private system. So in Canada, you cannot do both. You either work in the public system, and if you want to opt out, you have to leave completely. But even then, you can't charge more than the public system. So really, there's not a lot of incentive to do that. So most physicians don't do that. And the third thing he wants to be able to do is extra bill. So be able to charge patients more so that they could be seen faster if they're able to pay that extra amount. So as you can guess, if those three things ever happened, that would undermine the very foundation of Medicare in Canada. So we are at a point now, we're coming to a decision within about a month on this court case in BC. It will probably go to the Supreme Court of Canada, whatever decision happens. But should in the end, Dr. Brian Day is his name, and his team win this case, it would have repercussions across the country and would very much change the fundamental basis of our universal system.
Let's hope he loses.
I hope so. Yes.
We have tons more questions, and
oh my goodness,
we're going to put them up on a wiki page and hopefully get answers to them for everybody whose questions weren't asked. I'm going to use the privilege of the questioner to ask the final question, which is if you could give us one piece of advice about the fight and how we should go forward with the fight for Medicare for all in the U.S., what would that be?
Yeah, I think I've kind of touched on some things that I think are really exciting and possible in the U.S. that maybe could be lessons from Canada. And one is the fact that it was really public support as well as some key leaders that push this forward. So the work that you're doing is so very vital, because when you have the support of a broad population, that is enough to, push politicians and leaders. And if you can get those key allies on board in leadership positions who can push it forward, that's what happened in Canada, despite really stiff and able to provide universal equitable care. And so I look to you, and I'm excited to follow your path. And I just really hope that you can be successful and be far better than we are.
Thank you so much for your time, Monika. I know you need to put your son to bed. Really appreciate it.
Yeah, thank you, everyone.
I'm going to try and face her towards the audience.
Oh, we're going to help you see the audience. 1 second.
Okay.
1 second.
All right. Everyone ready to say hello to Canada?
I see. Hi, everyone. Oh, that's awesome. You were very blurry, but you're all beautiful.
Thank you so much.
Okay, bye.
Bye. All right. Okay.